Hi, Canyon County. This is going to be an attempt at education with the ventilator, our O2E700. Um, and the reason I'm doing this is because I want to get better at vent strategies and understanding what we can do when things go wrong, and just being a better clinician and a better patient caregiver. And I've heard that desire from many people. So this is my first attempt at this. I'll get better at it, I promise. If I can't explain things right, just let me know after we get this done, and I'll do something else. Okay. So this is the ventilator education O2E700 PowerPoint. Okay, I'm going to set this up here. This is another reason why we're doing this. So imagine getting a phone call and someone from the hospital tells you that your loved one is in the hospital and they are in critical condition and that you need to come down and be with them. So you get there and you see that they're on a ventilator, and I want you to ask yourself if you would be comfortable setting up the ventilator, knowing the strategies to use, knowing what to do, and the reasons behind it in setting up that ventilator for your loved one. And if that isn't an affirmative or of course I do, I've got this stuff, then why should our patients' loved ones trust us to transport their loved ones on a ventilator? How do we set things up? Why are we doing this? What do we do if we have issues in transport? So that is a big drive for me to be better at this tool that we have in our toolbox. So listing some of the objectives we're going to go over. When should we use ventilators? Of course, we should be using ventilators on our patients that are already vent dependent. We get the numbers and the tidal volume and the FiO2 and the respiratory rate and the PEEP and all those settings. That's easy. We don't have to think about that. We do have to troubleshoot if something goes wrong, but we don't have to, figure out the vent settings. They're already done. But what happens when we do have to do that? We're going to define some ventilator strategies. We're going to go over some definitions and terminology, and I'm going to try to explain what modes of ventilation are, and some of the basic ones, and what can we use according to the EMS Physician Commission, those guys that set our scope of practice, and what things we can and cannot do as paramedics. You're going to hear some of the things that I say we can't do as paramedics, but as a critical care paramedic service, they can do some things that we can't do. And I'm just going to give you that information. We're going to discuss some of the settings that we use and why we do that. And that goes along with understanding ventilation strategies and ventilator strategies and how we can vent someone without hurting them. And then, of course, alarms from our ventilators. I understand that they alarm a lot, but what do they mean, and how do we troubleshoot, and what things can we look at to correct so that those alarms don't keep going off? So those are some of the objectives. Okay, some more. When should we use ventilators? So obviously, when you have a vent dependent patient, you're going to set up the vent for them. It's easier for them. So that's an easy one. How about post-ROSC? So you have an LMA placed. Do we always have to intubate? No. Can we put a ventilator on a LMA just like we do with the ET tube? Yes, we can. It helps free up your hands. You've got a lot to do post-ROSC. You've got to do a 12 lead, get a good set of vitals, decide where you're going, start a couple lines, infusions afterwards, setting up your amiodarone drips and dropping an NG tube down, trying to figure out just how to support that patient so that they don't rearrest. So why not free up your hands? We don't have PEEP on our bag valve masks. And what does that mean? It means that if we have a problem with our patients splinting open those alveoli and recruiting those alveoli and maintaining them open so that perfusion, ventilation, all of the respiration that happens in that, in the alveolar capillaries and all that sort of stuff, the gas exchange. If we don't have PEEP on our BVMs, and we really need to get BVMs that have that, or get that little valve to put on a different BVM, every time we ventilate and release, we're de-recruiting, and it takes sometimes a long time to re-recruit the alveoli. So we're not helping our patients in doing that. So if we can set up the vent, put PEEP on, do all the things that we can to help properly ventilate and better ventilate our patients. So yes, we should be doing that. It's crazy in the back of an ambulance post-ROSC sometimes. So let's do something. Let's free up our hands and let's do better patient care. Okay, sorry. There's a call being dispatched, so I turned it off for a minute. Impending or actual respiratory failure. So we have a patient that we think we can turn around with CPAP or BiPAP, and using our ventilator can help do that. We can set a little bit better PEEP and pressure support if we need, so that their bodies can be supported, and hopefully we don't have to intubate those folks. So that's another use of our ventilator. Inadequate gas exchange. We've got patients that have VQ mismatches. We've got folks that need better oxygenation where it's supposed to be. So maybe we can help them with our vent strategies, increasing our PEEP, or recruiting those alveoli that aren't recruited right now. So those are some things that we can do to use our ventilators. Those patients that are fatigued and so worn out, their work of breathing is increased because of their disease process, and we decide to take their airway so that we can decrease their work of breathing and their body can go back into homeostasis. So our ventilators can help support them and provide their body time to do what it needs to do. Okay, so more reasons. Any patient, and we've talked about this, with an established, secured, and confirmed airway deserves and needs ventilatory support. So a vent support. It helps provide consistent support. We can manage their oxygenation, their PEEP. We can kind of look at their end titles and decrease or increase respiratory rate, increase, decrease tidal volumes based on some good science. So we really should use them. We already discussed ventilators free up a provider, and you know what? They're really fun. If you keep practicing with them and understand how this stuff works, they are fun. I just DSI'd a patient yesterday, put that person on a vent, and it was just so smooth. So smooth. I love it. Okay. All right. Some complications we're going to talk about. Our vents run with oxygen. If we run out of oxygen, it won't be powered. You know, you're not going to be ventilating that patient. So you always have to have a backup. Always have to have a backup. Back valve mask, have an extra oxygen tank sitting there. All those things will help us. Patient anxiety. So using analgesia and sedation. I'm going to harp on this over and over again, but just imagine yourself being intubated. You have this big 802 between your vocal cords. You're not in control. Something else is initiating your breathing. You wake up enough and feel that pain enough. What are you going to do? You're going to start fighting that tube. You're going to start biting down. You're going to start breathing out when you're supposed to be breathing in, and having a lot of anxiety. Have you ever seen your post-intubated patients have that tear in their eye? It's not because their eye is, feeling bad. It's because they can feel what you're doing to them, and it's not comfortable. Analgesia, sedation, analgesia, analgesia, analgesia. Whatever you use post-intubation, please do. Carrie asks us over and over again to make sure that we draw those up, even while we're setting up our intubation stuff, and then give it quickly afterwards. Improper settings. So giving too low or too high a tidal volume can cause massive complications, as well as too low respiratory rate. Are we making our patients hypercarbic or hypocarbic just due to our settings? We can't cause more problems. Increased intrapulmonary pressure, as well as the next one, cardiovascular compromise, pretty closely tied. So the more positive pressure that we put into them, the higher chances of having that increased intrapulmonary pressure and the cardiac compromise that comes with that. Low cardiac output and stuff, and just from the positive pressure, as well as from the medications that we've used to induce and post induction stuff. So always keep that in mind. GI disturbances, air in the gut causes a mess. We understand that. Infections, pneumonias, ventilator lung pneumonias, all of those infections, not good for our patients in the ICU setting. Impaired clearance and drying of secretions. We see that a lot with long-term oxygen use, and just imagine having a ventilator going on you. And the biggest ones, some of the biggest complications that we talk about in here is ventilator lung injury and ARDS, and what some massive tidal volumes can cause some ventilator lung injury, causes the inflammatory process to happen, and then they've got fluids just pounding in on the alveoli, and all of the sequelae that happens with that is just not a good thing. So we do not want to produce ventilator lung injury and ARDS with the strategies and the vent settings that we use. We're going to go through some basic definitions, and we'll spend more time on each one of these. So minute volume, tidal volume, frequency or respiratory rate, ideal and predicted body weight, and how to figure those out. Some basic modes of ventilation. I'm not going to go into real advanced modes at all because we can't use them. We might as well not spend a whole lot of time right now doing that. PEEP, how do we use it? How do we utilize it? Our plateau pressures, our inspiratory pressures, high, lows, what's going on? Inspiratory, expiratory ratios, I to E ratios, and last, some ventilation strategies that we can implement right now with our patients. Okay, minute volume, very, very important concept when talking about and understanding ventilators. So what is minute volume? You know the definition. Minute volume is the amount of gas inhaled or exhaled from a person's lung in 1 minute. That would be plural, lungs, sorry. So we have minute volume. We also have alveolar ventilation, which is pretty important. What is actually getting to our alveoli? And that's a very important concept to understand as well. If we know our respiratory rate and we know our tidal volume, we can figure out our minute volume, because as this formula shows you, our minute volume is our respiratory rate multiplied by our tidal volume. And we know both of those when we're setting up ventilators, because that's what we input into those things. Do our circuits cause dead space? We understand from before our dead space from our trachea, our bronchi, and all that sort of stuff. Well, our ventilator circuits create dead space. Our ET tubes create dead space. Our in-tidal CO2 things that we put in between our bag valve mask and our ET tubes, that is more dead space. So we'll look at that in a later section, but it is pretty important. So normal minute volume, what is that? You know, you remember from anatomy and physiology class. So at rest, an adult usually utilizes about 5 to 8 liters per minute. That's a normal minute volume. And we understand as our activity increases, so does our demand for more oxygen. How do we affect minute volume? So both our tidal volumes as well as our respiratory rates that we input, that is affecting minute volume. We can't have an adult have a minute volume of 3 liters. That would be improper vent settings. So we've got to understand what that is. So hold on a second. Okay, sorry, I was just making sure that the next concept was on the next slide, so it is. Okay, oxygen consumption and alveolar ventilation. While at rest, we consume about 60 mils per kilogram per minute of oxygen, right there. So, does this change with being intubated and being put on a ventilator? Yes, it does. It changes. Our dead space increases. We just talked about this. We lose about 1 mil per pound of ideal body weight, or about 150 mils per breath with our circuits and with our ET tubes. 150 mils per pound. That's or breath. That's a lot. So due to that dead space, what gets to our alveoli is less than our minute volume. So this last slide here, to account for this dead space in our circuits and stuff, we need to take that 60 mils per kilogram per minute and just double it and make it 120 mils per kilogram per minute. So we can calculate and help with that loss of volume that it was not getting to our alveoli. So we're going to do an exercise doing that right now. Okay, we're gonna try this. We're gonna use an 80 kilogram patient. We remember our formula to help us with our dead space. So we're gonna multiply 120 mils by 80 kilograms. So that gives us about 9,600 mils, or 9.6 liters. That's our target minute ventilation for that patient. And remember, our minute ventilation, that is our tidal volume times our respiratory rate. So we need to now figure out our tidal volume based on our protocols and what we can use. So our protocols say that we can use 6 to 8 mils per kilogram. So our 80 kilogram patient, we're going to start at 6 mils. So we're going to get a tidal volume of 480 mils. Okay. So I've got my tidal volume. I've got my target minute ventilation. I can figure out a respiratory rate now, right? Yes, I can. So to calculate our respiratory rate or frequency, we're going to divide our minute ventilation or minute volume of 9,600 mils by 480 tidal volume, and that's going to give us a respiratory rate or frequency of 20 breaths per minute. That 480 mils of tidal volume going at 20 breaths a minute is going to give us a good solid minute ventilation of 9,600 mils. So that's great. That's what this is. Might be a test question. So this is important stuff. Remember our old vents? We used to have those cards that had our minute ventilation and what our tidal volumes and respiratory rates were based off that minute ventilation, and I thought that that was just silly. Why not just set a tidal volume and a respiratory rate and on you go? Well, it's all about this minute ventilation, and I understand how ignorant I was and how, I thought that using those cards was ridiculous, but it's all about minute ventilation. It's all about getting the ventilation to that alveoli and helping that oxygenation. So I feel silly that I was so ignorant. All right. Okay. Kind of talked about tidal volume, but let's discuss it a little bit more. So we understand the tidal volume is that volume of air moved into and out of the lungs with each respiratory cycle. How much is appropriate? We already discussed our protocols allowing 6 to 8 milliliters per kilogram, and that's based off that ideal or predicted body weight. And I promise you we'll get to how to calculate that in a bit. But why? Why is that okay? Why is 6 to 8 mils per kilogram okay? As discussed a second ago, that ventilator lung injury and that acute respiratory distress syndrome is some pretty bad stuff. We have to be careful not to cause ventilator lung injury. In the late 90s and 2000s, a group called the ARDSNet group dedicated research and lots of randomized controlled multi-center studies on morbidity and mortality based on volumes, tidal volumes, and what's good and what's bad. So traditionally in the old days when I was a young paramedic, they used to use 10 to 15 mils per kilo on those ventilators. They just wanted to recruit that both entire lungs, just keep that stuff opened up, keep those alveoli opened and recruited using those high tidal volumes. And one of the studies that they did, the ARMA study, that was in 1998, they directly compared a 12 mil per kilo tidal volume versus a 6 mil per kilo tidal volume, and they found that they had a lot more reduction in ventilator lung injury in that ARDS stuff, that acute respiratory distress syndrome. So what happens with that ventilator lung injury and that ARDS stuff? What they found as well in animal studies is that high tidal volume was the overdistension of that normal lung tissue causes, number one, parenchymal inflammation, so lung tissue inflammation. Increased vascular permeability, that's not a good thing. Abnormal accumulation of fluid in the lung, that causes alveolar flooding, causes atelectasis, causes the infiltrates that you see on x-ray, causes hypoxemia from shunting. So those high tidal volumes are not good. On the other hand, low tidal volumes are not good too either. Our hypoventilating is not a good idea as well. So our low tidal volumes are not good. We will cause hypoventilation, hypercapnia, acidosis, and those are not good things. So we want to be in the right, that sweet spot, that 6 to 8 mils per kilogram. There was another study they did, the alveoli study, and at the end of this lecture, there's a slide with some of the links and stuff to this stuff, so you guys can read this stuff too. But they found that the acute lung injury, the respiratory distress syndrome, all of that stuff can happen with sepsis. It can happen with massive aspiration, as we know. It can happen with these large tidal volumes, injuring the lungs, that causing the inflammation, the increased vascular permeability in the lungs, the extravasation of the protein-rich fluid into the interstitial space in the lungs, and the alveolar space. What do you think that's going to cause? That's going to destroy the surfactant. So decreasing that surfactant production and all of the inflammatory processes that happens with the ARDS and ventilator lung injury, it's going to increase the surface tension and cause that, micro atelectasis happening with our alveoli. So not a good thing. We can't gas exchange through that. So that's why high tidal volumes are not good. And you can look at those studies. It's kind of cool to get on that ardsnet.org website and see what they've done. There's also another, the ardsnet.org, I think a couple of years ago, stopped doing research, and there's another research group called the Petals Group that is doing more research and expounding their research as well, not just on ventilator lung injury and ARDS, but kind of cool stuff. So if you would like to figure that stuff out and look at those studies, you're welcome to do that. Okay, let's talk about our respiratory rates. Kind of figured out how to find our respiratory rates already, but our frequency of respiratory rates, and we understand that that through those studies, the ARDSNet studies and stuff, that those higher tidal volumes and low respiratory rates were giving them a good minute volume, but they were injuring those lungs. They were causing ventilator lung injury. They were causing that ARDS. So those studies showed us that we need to use strategies that protect our lungs. And a lower tidal volume and a higher respiratory rate is going to assist that and help that. So decreasing those complications by using a lower tidal volume of that 6 to 8 milliliters per kilogram, and then figuring out our respiratory rate based on our minute ventilation. So those lung protective strategies, we're going to use a lower tidal volume, higher respiratory rate, and 18 to 20 is what our normal respiratory rates are going to be. How many of you have seen and used, as I have, crash ventilator settings? I didn't know much about this stuff, but it's grossly inadequate to put a tidal volume of 500 and a respiratory rate of 10. It's in a patient that's oxygen demand has gone up, There's an insult to their body. They're going to need more oxygen. We just put them on a vent circuit that's going to take out about 150 mils of that air getting down into those alveoli. So we're not doing any good with just using crash ventilator settings. I didn't know that. But I'm educating myself, and I'm trying to help you guys see this as well. So that rate, lung protective strategies with our tidal volume, our rates are going to help us keep our minute volumes and our alveolar ventilation up. We pretty much just answered this, how our respiratory rate affects our minute volume. And then we just looked at minute volume and kind of filled in the blanks with the tidal volume and our respiratory rate. I want you to think about this though. With our patients in serious DKA that have been sick for so long and we need to intubate them, aspirin overdoses, that high metabolic acidosis that we're going to see with those patients respiratorily, they're trying to compensate, right? They're trying to blow off the excess acid and CO2 out of their systems. Those patients are not going to do well with a respiratory rate of 18 or 20. We have to, on those patients, double that respiratory rate because we have to keep them close to their physiological compensation as we can. And so we might see those patients with a tidal volume of 480 and a respiratory rate of 36 or 40. And we have to do that with those DKA patients and with those aspirin overdose patients, those patients that are in serious metabolic acidosis. Okay? We need to meet our patients' oxygen demands. And our respiratory rate is going to help us do that with our lung protective ventilator tidal volumes that we're going to be using of 6 to 8 mils per kilo. Okay, so riddle me this. Does a 5'10" male patient that weighs 350 pounds have larger lungs than a 5'10" male patient that weighs 150 pounds? No. We all know that. Ideal body weight and predicted body weight. So how do we figure it out? Well, there's a formula. Oh, no. So predicted body weight is based on height. Ideal body weight is based on height. It's based on how long your lungs grew, you know, to fit your little 5'10" frame or your 4'9" frame or whatever it is. It has nothing to do with the extra weight that we're carrying or how much we weigh or how little we weigh. It has everything to do with the length of our lung tissue itself. So that formula is based on height. With males, if they're 5 foot tall, they automatically get 50 kilos, okay? And then every inch after that 5 feet, you multiply however many inches by 2.3. You add it to 50, and you get their kilograms based on their ideal body weight, based on their height, okay? So let's do that. We're going to work with are we going to work with a 5'10" patient? Yes. So 5'10", we know that they automatically get 50 kilos for that 5 feet. And then that 10 inches, we multiply 10 times 2.3. And it's pretty easy math, even for me. That's another 23 kilos. So that 5'10" patient weighs 73 kilos. So we are going to base that 6 to 8 milliliters per kilogram on their body weight, and that's the ideal body weight, and that is the formula. Hint, that might be one of the quiz questions, right? Now, males are inherently larger than females. So females have a different little formula. So here's our 5'10" male, 10 inches times 2.3, 23, and add that to 15, get 73 kilos. So for females, I just gave you the answer, but that's okay. That 5 foot for females is 45.5 kilos, okay? And then the same with the inches with the females. We, this is a 5'5", so 5'5", so we'll multiply that 5 inches by 2.3, and we will get 11.5. Just add that together, and you get a 57 kilo patient. Now, it is difficult, I understand, to guess height when someone's laying on a stretcher. It's easier, as we all know, to guesstimate somebody when they're standing up, because we kind of look, we know how tall we are, and we kind of look at them and say, okay, they're 5'8", because they're 2 inches taller than I am, or 5'10", or whatever the case is. Last night when I intubated that patient, I asked the spouse before I left, I said, how tall is she? And he told me she was 5'7". So let's do that together, okay? Most of the time, they know. In my ex-marriage, we used to fight about how tall my husband was. Because he said that the Army said he was 5'10", and I said, because I think you're not as tall as that, but that's okay. I'll let him think he's 5'10". All right, so this female automatically gets 45.5 kilos, right? And then we're going to multiply 2.3 and 7. And we get 16.1. So we'll just add 16 onto there, and we get 61 kilos. And guess what I did? I dropped the 1. It's kind of an estimate anyway, so I just used the 60 kilos. How's that? Predicted body weight. All right, now here, as a fun fact, there are shorter people. Megan. All right, you know, when I lecture, that I kind of am pretty impersonal. That's why this is like this, because I can't talk and lecture any other way, so sorry. So what about those folks that are less than 5 foot? So say we have a 4'10" female, okay, a little less than 5 feet. Stand by 1 second, I have to cough. Okay, sorry, I had to cough. So for an under 5 foot person, we are going to subtract 1 kilogram for every inch that they're under 5 feet. So this 4'10" female, that's a female, is 2 inches below 5 foot. So she gets 45.5, and then we subtract 2 kilos per inch less. So we're going to subtract 2 from that, and we get about 43.5 kilograms. Okay? Same with the man. So a 4'10" male, we're just going to subtract that 2 kilos from 50 instead of 45.5. So that would be 48 kilos. Okay? All right. Easy enough with predicted body weight. And guess what? We have cheats. Next slide will help us with those. All right, I like the KISS method with anything. So KISS method for predict body weight. Instead of doing the 2.3 kilos, multiply by however many inches above 5 foot. If we just knock off that 0.3, it's not going to be, it's going to be a very negligible difference. So you can see that 5'10" patient, 50 kilos for the 5 foot, and 2 times the 10 instead of the 2.3, and that would be 72 kilos. Same for the females. Instead of the 4.5 and the 2.3, let's just take those off right now. So 5'5" would be 45, plus the 5 times 2 for the inches would be a 55 kilo patient. Okay, I like the keep it simple, stupid method. It's pretty much kind of a guess on how tall they are. It's great if they know exactly, but is that, you know, a true 5 foot 5.5 inches, 5 foot 5 3/4? You know what I'm saying? Get what I'm laying down. So just estimate on that and take off those decimals. I also have tools. We have tools to use, some cheat methods. We have printed out tables that have that already calculated for males and females. Those tables have a 4 milliliter through an 8 milliliter per kilogram calculation already put in there. So you just find a 5'10" person, you can see how many kilos it is, and then you'll look for whatever you want to start out, whether it be 6 or 7 or 8 meals, and it will calculate that for you as well. I also have this thing called a volume tape that I had bought, and basically this is a Broslow tape for height. So it's going to measure, I'm going to measure it on adults, it can measure kiddos, it could go down to 1 inch all the way up to 7 foot. So, and then it also has the calculations for males and females for the tidal volume. So I have this, I think it cost me $30. I've been using it. I actually measured somebody to intubate, and it gave me the tidal volume, so that was kind of fast. So that's called a volume tape. This is the National Institute of Health predicted body weight and tidal volume chart. That's not like waves. So males and females, you can see it goes from 410 for adult males and 4.7 for females. It goes all the way up to 6.6 and 6.3. So there you go. And then it has the 4 mils all the way up to 8 mils per kilo already calculated. So there you have it. I will get a chart. I will laminate them and put them in the vent bags. Okay. Okay, Steve. All right. So use our tools. Thank you. Okay, let's talk about some of the basics for modes of ventilation. And the mode of ventilation is the way that the spontaneous or mechanical breath is delivered. I'm not going to talk about some advanced ones like pressure regulated volume control or airway pressure release ventilation. The high frequency ventilation that they use on neonates, the jet ventilation and all that sort of stuff. I'm not going to talk about that. But we are going to talk about assist control volume. We're going to talk about bilevel and BiPAP, CPAP, and SIMV or synchronized intermittent mandatory ventilation. These all can be used in volume control, which is what we as the common paramedic can do, or pressure support as well. I'm not going to talk about the pressure support part. So there's many others. There's using heliox, there's using nitric acid. Oh my goodness, oxide. Sorry. So some of the basics that that we're going to talk about. Okay, let's talk about this basic mode called assist control volume. And this has been used for years and years in ICUs and in the EDs. It's a great mode. It does have some complications, but basically this set tidal volume that you put in is delivered at a minimum set rate. Now the assist part is if the patient triggers a breath themselves, then the ventilator is going to assist that and give them that same tidal volume. So additional ventilator breaths are given if the patient triggers that breath. What are some of the complications of that? Well, in the hospital, not as many as in the transport environment due to some triggering that can happen because our vent circuit shakes real bad, or there's a bad road in Napa or Caldwell, heaven forbid, and that kind of falsely triggers a breath. Our patient isn't triggering it, but it's falsely triggering it due to movement or vibrations. Our patient that is not controlled with sedation and analgesia can just draw a breath, start to breathe, and it gives them that 550 tidal volume that we set, and it could cause stacking of breaths. So this assist control is great. It's something that we can use. This is what we can use. We cannot use SIMV. We're going to talk about that in a minute, but according to the EMS Physician Commission, we have to use assist control volume. Okay, so that's what we're. Okay, let's talk about advantages. I just did talk about some disadvantages, but number one advantage, it's in our scope. We can use it. Yay! It helps control the work of breathing so that their muscles in their body can recover from that fatigue that they've had. It does allow the patient, if they overbreathe that ventilator, to set their own respiratory rate. It's just going to assist them with that entire tidal volume, and that can cause that breath stacking. So we always need to remember that good pain control and sedation strategy. Please, please, please keep that pain control and that sedation down, okay? Okay, CPAP. We've been using it for years. It's great. That CPAP mode, the ventilator delivers that continuous airway pressure to generate the continuous pressure so that they breathe against that expiratory pressure. Helps keep those airways splinted open. We start that at 5 to 10 centimeters of water pressure. You can use pressure support as we have been, like is on this vent right here. We've got a CPAP pressure, 5 centimeters of water pressure, and then the pressure support is set at 10 here. Okay, we've talked about some of the benefits. Reduces that work of breathing, improves that atelectasis by decreasing that. It kind of helps splint or keep those alveoli open, so the VQ ratio mismatches are decreased and you get a lot more oxygenation as well as offloading of the carbon dioxide. We know it's to help us treat pulmonary edema, CHF, COPD, and asthma. So improves oxygenation and hypercapnia, increases the functional reserve capacity, which is a great thing, helps splint open those alveoli. So that CPAP with pressure support is like BiPAP. So it provides an inspiratory and an expiratory pressure. So what we have to realize, though, is that peak inspiratory pressure is going to be your inspiratory pressure, that pressure support that you dial in. So say we'll do that 10, and then that CPAP we set at 5 usually. So that peak inspiratory pressure for that CPAP right there is actually going to be that 5 centimeters of water pressure additive with the 10 pressure support. So that peak airway inspiratory pressure is going to be 15 centimeters of water pressure. So if they can't handle that, or if it's not seeming to help, you can dial both of those up a little bit or down a little bit to help that them to overcome the problems with that high pressure. Okay, let's talk about BiPAP bilevel. Hey, we can use this. It has been approved by the EMS Physician Commission that we as just regular paramedics can use this bilevel support. So we can use this now on our ventilator. So exciting. So it's like CPAP with that pressure support. So an inspiratory and expiratory pressure is set just like that CPAP with the pressure support ventilation. We can use it. And interesting, the bilevel mode is similar to the SIMV mode with pressure support. So you set that inhalation pressure, or that PI pressure right here, and the exhalation pressure, or that PEEP. So the ventilator delivers that pressure control mandatory breath at a set breath per minute, okay? It's similar to the SIMV with pressure support in that the rate rather remains constant, and the time of spontaneous breathing, that window that they can trigger, it resets or changes if they trigger something. So if they trigger a breath themselves, then that window resets, so they are less likely to stack on this. So that's pretty cool. So try it. I've been playing with these modes, cleaning the circuits and masks off, putting it on myself, and going between CPAP and bilevel. And for me, the bilevel is a little bit more comfortable, but I can tolerate the CPAP just fine, and the bilevel as well. So just play with it, okay? That's how you kind of figure out if it's comfortable or not, and kind of figure out how your patient is doing. And if you start on bilevel and they're not doing very well on it, go back to CPAP with pressure support. You know, we've got options here. Okay? Okay, this is just what we talked about on that bilevel. Start with our inspiratory peak airway pressure, that IPAP at 10 centimeters of water pressure, that expiratory peak airway pressure, or EPAP, of 5, just like we've been doing. Adjust as needed based on your patient's response, whether they can tolerate it or not, or need some more assist or not. If they're really hypercapnic, maybe decrease that expiratory pressure a bit, okay? Okay, let's talk about SIMV. Now, according to the EMS Physician Commission, we cannot use SIMV, not a regular paramedic. A critical care paramedic can. So if you're working for somebody that has their critical care paramedic license, that they do those critical care things, like I don't know, ASL, I guess, then you can use this synchronized intermittent mandatory ventilation. So please, here at Canyon, we don't have that designation now. Don't use this. I clarified with Carrie, because I tried to say, hey, this is a volume controlled mode. So, but she said that the EMS Physician Commission had dubbed it an advanced mode. Whether I agree or not doesn't matter. Okay, so the vent is set to deliver a predetermined number of breaths per minute, right? Just like assist control volume. In this mode, if the patient initiates a breath themselves, so triggers a breath, then it resets that window when it will ventilate on its mandatory ventilation cycle. So it delays the machine breath to prevent breath stacking. It's an awesome, awesome mode that we can't use. So unlike assist control, any spontaneous breathing does not involve a machine-delivered breath, okay? So if pressure support is used, it will augment a patient's initiated breath, okay? Again, we can't use this, y'all. Okay, I'm teaching you right. Okay, PEEP. We're at PEEP. We know what that is. We've been using it. Positive end expiratory pressure. It's the alveolar pressure at the end of the exhalation or the expiration. Maintains alveolar recruitment. So we want that. We want those alveoli to stay nice and plump and open. We don't want them shut and shunted down. It helps optimize the ability to provide effective oxygenation. We usually start that at 5 centimeters of water pressure. Centimeters of water pressure. Okay, I took my ugly mug off of this so you can see that nice, awesome alveoli there. Pretty cool. So let's talk about plateau pressures. Okay, you might hear it as P-plats. Plateau pressures are, this pressure is a direct indication of the alveolar function, the alveolar health. Okay, we know that with ventilator lung injury and ARDS, that high plateau pressures can cause those issues. Okay, so we need to keep our plateau pressures, our alveolar pressures, less than 30 centimeters of water pressure. So what are some of the things that cause high plateau pressures or high P-plats? A large tidal volume can. It's just gonna get that lung all distended out. Decreased pulmonary compliance. Think about your emphysema patients, that decreased, stretch in the alveoli and all that. And some disease processes as well. Pulmonary edema can help, that can cause that plateau pressure to rise. Pleural effusions. So gut insufflation, tension pneumothorax, Trendelenburg position, I mean, we used to use Trendelenburg a lot in our, actually it's just shock position because true Trendelenburg is head down, feet up, but we don't use that anymore much, which is a good thing because it can cause high P-plats. Ascites, anything that is pushing on that, diaphragm and stuff. Pregnancy, that's weird. All right, so high plateau pressures are not good things. And I'm going to show you a time curve or a pressure curve and then I'm going to explain what your peak inspiratory pressure or your PIPs are and where your plateau pressure is next. Now, when we are looking at our waveform on our ventilators, we can check a plateau pressure. And I have a video in here on how to check a plateau pressure. But when you get that waveform, when you see that waveform, you're going to see this plateau or this big old rise in that waveform, and then you're going to see it drop off, and that will be your plateau pressure. That is your P-plat pressure, and you can kind of tell here that it is about 20. So this is the peak inspiratory pressure, which I am going to talk about in just a second, and then this leveled off is your plateau pressure. What is that plateau pressure? That's your alveolar health. That's the pressure in the alveoli. That if that pressure is high, above 30 centimeters of water pressure, we can be causing that ventilator lung injury and that ARDS. So we don't want to do that. Okay, I'm going to check my plateau pressure or my P-plat. This is an assist control volume mode. My tidal volume, as you can see, is 450. My rate is 16. I have a PEEP of 5 there, and I'm on 100% oxygen FiO2. So I want to check my P-plat to document that. I'm going to push this manual mode on inspiration for about a half a second. And then what you're doing is you're looking at this graph here, or this waveform rather, and we want our P-plat to be less than 30, right? So the initial rise is going to be your PIP, your peak inspiratory pressure, and then it's going to level out and give you your P-plat. So it's alveolar health. Here's what we're going to do to check that alveolar health here. So I'm going to inspire, hold it for a second. All right, did you see that? That was kind of cool. So I'm going to do it again. Okay, so see that top is the PIP, and then down here is that P-plat. So I'm going to do it again, and then I'm going to point. All right, so inspire. Yeah, I'm going to wait till that graph is in the middle, or the waveform is in the middle. Okay, so PIP is that top, and P-plat is here. And as you can see, it's not more than 30, because 30 would be up here. So we're still doing really well on our PIPs and our P-plats. So that's just a demonstration on our vent, how to check our P-plat using our inspiratory hold for 0.5 seconds. Okay, so now I just taught you how to check plateau pressures in using our ventilator. So we're just going to hold down that inspiratory hold, that hold button, that manual hold button when they inhale. So we're going to hold it down for a half a second, and then look, you're going to have to look at that waveform. And you can see there's a 20 and a 30 and a 40. You'll see that high PIP pressure, and then it's going to go drop down into that P-plat pressure, and that is what you're looking at, trying to keep your P-plats below 30. Okay, so now let's talk about our PIPs, or our peak inspiratory pressures. So this pressure is everything above the alveoli. So things in the pressure in your trachea, in your bronchioles, in those big airways. So everything above the alveoli. We want to keep that less than 40 centimeters of water pressure. So what can cause increases in PIP? That peak inspiratory pressure. So increased secretions. Just think about the large airways. So increased secretions. So what do? We suction. Bronchospasm. Okay. What do? We give bronchodilators. What if the patient is not properly pain control with sedation, and they're biting that tube? They're fighting. That's going to cause high PIPs. Decreased lung compliance, maybe due to the disease processes that they have, or increased pulmonary edema, or anything like that. So you know how our tube comes out of the mouth, and then we have our end tidal, and then we have the circuit, and that's huge. It's like a big giant thing. And what if that bends over? I've had to hold them up, so that it doesn't bend over. And then again and again, needing pain control and sedation. So we want to make sure, if we have high PIPs over that 40, you need to look at this stuff. Do I need to suction? Do I need to give more bronchodilators? Are they fighting? Are they biting? Do I need to give them, if that was me and I'm out of control and I can't breathe right, this machine's breathing for me, it will be very uncomfortable. So please, if you intubate me, give me lots of pain control and sedation, okay? All right. Okay, I to E ratios, just real briefly. This refers to the ratio of inspiratory time versus expiratory time. And we know when we breathe normally, our normal exhalation is about twice as long as our normal inspiratory time, right? So our vents are set up to automatically default to a 1:2 I to E ratio. Now, if your exhalation is is not long enough. It's insufficient in duration. This leads to them not being able to get all the way down to the bottom of their exhalation, and this leads to auto-PEEP, which causes hypercapnia and hypercarbia. This is not what we want, especially with our obstructed patients. We have to give them sufficient time to exhale. Most of our obstructed patients, our asthma, our COPDers, they can breathe in fairly well. That exhalation, that's when we hear all those wheezes and stuff, is constricted, so they're unable to get all that out, and they keep having to work hard. And when we exhale, it's a passive process. When they exhale, they're expending a lot of energy, and they're increasing their CO2 levels, and they're just not able to get that out. And that's why we need to make sure that we have a good I/E ratio. So if, as an example, if you have a respiratory rate of 10, that would be a 6-second respiratory cycle, right? Because 60 seconds divided by 10 is 6. So in an I/E ratio of 1 to 2, your inspiratory time will be 2 seconds and your expiratory time will be 4 seconds. So it's double that inspiratory time. And that gives them enough time, hopefully, to breathe out. Now, advanced settings, when you have a really obstructed patient, you're going to find your critical care paramedics might increase their I/E ratio from 1 to 2 to maybe 1 to 3, 1 to 4, or 1 to 5. We can't do that. That's a critical care thing. But I'm just trying to explain what this I/E ratio is. Next on our objectives is what we call ventilator strategies. How do we set up these ventilators? And I'm going to talk about 2 approaches. The obstructive approach, those are strategies that we use on our obstructed patients only. Asthma, COPD exacerbations. That's it. Obstructive approach, asthma, COPD. Our injury approach basically is everybody else. So this is the strategy that we're going to use to protect their lungs, okay? So this is a strategy that we can use with patients with already diagnosed lung injuries like ARDS, VLIs, and those that are prone to lung injury. So everybody else gets injury. Obstructed gets obstructive. Okay, let's talk about the injury strategy first. And this is a strategy to protect their lungs. We use the 6 to 8 mils per kilo. First, we do select the ACV mode, the assist control volume mode. We're going to figure out the tidal volume using the 6 to 8 milliliters per kilogram of predicted body weight. Our respiratory rate or frequency, we're just going to set it 16 to 18 breaths a minute, okay? We're going to understand that we're going to have to double that respiratory rate if they're severe metabolic acidosis, DKA, or aspirin overdoses. You're just going to have to double that respiratory rate. But remember, 6 to 8 milliliters per kilogram predicted body weight. Injury strategy, we're going to have a frequency or a respiratory rate of 16 to 18. Okay, and we're going to start the PEEPs at 5. That's pretty easy. That is the first strategy that you understand. So say you have a patient that is overdosed, that's very, very obtunded. What strategy are we going to use? We're going to use this injury strategy. We're going to select ACV mode, tidal volume 6 to 8, respiratory rate of 16 to 18, and we're going to start the PEEPs at 5. And we're going to see where we're at, okay? Pretty easy, pretty easy. Okay, let's talk about the other strategy, and this is our obstructive strategy. This is our asthma and COPD exacerbations, okay? They need time to exhale, okay? So our respiratory rate is our protection here. In the injury strategy, Our tidal volumes are our protection. We don't want to cause ventilator lung injury, okay? In our obstructive strategy, these folks need to be able to exhale, okay? So we're going to select again AC volume mode. Tidal volume is going to be 6 to 8 milliliters per kilogram of predicted body weight. And our respiratory rate, let's start at 10. This gives them that full 4 seconds to exhale. And some asthma and COPD patients don't need high PEEPs. Sometimes we don't need to start at 5. Sometimes we can start at 3. If they're struggling with that PEEP of 5 that we set, knock it down. Let's decrease it. They don't necessarily need that PEEP, but they do need that time to exhale. Two very easy strategies: obstructive and injury. These next slides are just setting up that ventilator, okay? So I'm going to let you go through those by yourself without me talking through it, and I'm going to meet you over at the troubleshooting part. All right, we're going to go through some troubleshooting alarms and possibly how to figure out what's wrong with those alarms. So the visual and audible alarms will continue to alarm until you mute it, and then the visual alarm will continue until the problem is resolved, just so you know. This alarm is a breathing circuit integrity. So what can cause a breathing circuit problem? A leaking mask, a leaking ET tube, disconnected patient circuit, any of those things can. So just fix it. Make sure the mask fits. Secure all the patient circuit pieces. And if that doesn't work, change the patient circuit. This is a low airway pressure. Remedy: replace the hose, check the tube position, check ventilation settings. If it has too low of tidal volume, yeah, just check it. High PAW, so high peak airway pressure. Again, kind of like our high PEEPs, check the tube position, kink tube, secretions, mucus plug. Do we need more pain and sedation? Is there more bronchoconstriction happening? Small diameter tube placed. So if you put a small tube in and you should have put a bigger one in, it's going to have a high low minute volume. So what can affect our minute volume? Our tidal volume and our respiratory rate. So redo your math. Make sure everything's good. Okay, high minute volumes. So guess what can cause it? High tidal volumes, high respiratory rates. Reset. Low inspiratory or inhalation pressure. Check your mask seals. I found that coaching the patient to not fight against that exhalation, stop talking, all those might help with that low and high inhalation pressures as well. Apnea, I don't think I have to explain this one, but some of the remedies with this alarm, switch it to assist control volume. If they're in a CPAP mode where they need to be spontaneously breathing and they're not, it will automatically default to ACV mode if they haven't triggered a breath with the trigger window. So I think it's 20 seconds right now is the default. Ensure your connections are tight. Replace the circuit. Low oxygen. So this is giving you a warning. You have between 40 and 21 psi still left in there. This is saying, hey, you need to change that tank rather quickly. finally no oxygen, so less than 20 psi. This is if I didn't get the tank changed out when it was low oxygen. Now I just ran out of oxygen. Your patient's not going to get any assist or ventilations at all. So take the mask off. I don't know. Use a BVM, whatever you need to do. Change that tank out and get that extra tank out so that you can change it again if you need to. Okay, folks, I hope that wasn't too painful. I appreciate your time a lot. And again, I've left some resources here. I listen to lots of critical care podcasts. Scott Weingart, the MCRIT, Eric Bauer with the Flight Bridge Ed. I listen to Sam Ireland, Tyler Christofoli. I think those guys are on Foam Frat. Anyways, just look out there and start listening to ventilator stuff. It is really cool. I hope you have a good day today, and good luck on your quiz. Okay? Bye.